All right, welcome to another episode of the Gestalt Education Show. We are excited to have another Clinical Savant Series participant today. So we are sitting down with the world's expert when it comes to gait evaluation, Dr. Courtney Conley. So Dr. Conley practices in Golden, Colorado, and we're excited to be sitting down with her today and kind of get into some nuts and bolts of gait and what it means in clinical practice and what your ideas on, I guess, where gait fits into the eval and how we can use it in assessment. So
Courtney, in school you're taught Parkinsonian gait, you're taught, all these like neurologic gaits. So maybe if you could inspire all of our listeners on why gait evaluation is really important in the exam and how it's probably not getting done like it should, and maybe motivate us all on that idea.
Yeah, I mean, it is one of my favorite things to do because I think it's such a window to everything else that you're doing, right? So it's just a huge window of opportunity to really assess the patient. And in school you're taught all of these, I don't know if scary is the right word, but these neurological gait patterns, and when in reality, if you just watch most people walk, there's so many things that can get pointed out to you from a functional perspective. And people come into our offices mostly to decrease pain, right? And I always say that's the easy part, right? Like getting rid of the pain is the easy part, but correcting function and improving efficiency, I think that's where it's at. And I think a lot of that comes with evaluating gait. Mm-hmm.
Yeah. We always kind of joke like how you got your foot fetish, like myself, you, or like so.
Minute 48, and we're already off the rails. Perfect.
So I guess what enamored you originally about the foot, the lower extremity, and gait? When you could have gone down many different areas, why did you choose to kind of go down the route that you did?
I spent a lot of my younger years in ballet, believe it or not, in point shoes. And then I became a triathlete when I was in Chicago, so about 15, 20 years ago. And I just was chasing a lot of dysfunction. Nothing really seemed to be efficient with my movement. And then I started, I worked in a couple orthotic labs, and so I figured, well, let's just start bracing everything. I'm going to brace the foot, I'm going to get an aggressive shoe, I'm going to start to brace my motion, and it never panned out. It was, something might have gotten better, at the foot, but then I was knee, and then so I was just always fascinated with the mechanics of the foot, and I was like, why are we doing this with our patients? Why are we bracing the foot when there's so many beautiful things that can happen there if you just let it do what it's designed to do? So I kind of went down that rabbit hole of going from, trying to eliminate its motion to understanding its motion and then trying to get it stronger and more efficient.
Yeah. Most of our listeners are going to know who Tom Michaud is. Who is maybe a name that no one's heard of that you really like to, whether it's a book or whether it's, a seminar series, or who's blowing your mind that maybe our listeners have never heard of?
Yeah, people always ask me that question, what books do you like? What? And there's just not a lot out there on foot and gait. I'll tell you, the researchers that I've been really loving is Irene Davis. She does some great work. Ebony Rio, Joe Cook, kind of getting into all the tendon work. I think I think we're going to start seeing more of researchers looking at, I don't want to use the word barefoot because people get all
philosophical then.
Yeah. And it's,
or in their
they're like,
right?
She's a hippie. She wants everybody to walk around barefoot. Right. And that's not the case. But I think we're hopefully going to start to see a lot more research being like, hey, let's take our shoes off and let's see what we can do to restore function here. So I think more of those kind of research names are going to be popping up more.
Yeah, that's cool. We always say, well, I think I stole it from Brett. Maybe you were saying shoes are basically like sensory deprivation chambers. And one of your points today at the RTP Symposium is that sensory and motor functions are very closely intertwined. And so how maybe have you found, the sensory system and the motor system integrating, and how are some of those assessments that you use in gait and foot and lower extremity?
Oh, yeah. I mean, it's huge. I think the easiest assessment is just watching someone balance with the shoe that they walk into your office in, and then have them take their shoe off. I mean, there's 200,000 plus sensory receptors on the bottoms of the feet that are screaming to feel something. If you watch any baby in the world, the first thing they do is take their shoes off, right? Because they want to feel. They're trying to gain as much sensory information from their environment as they can. And then as we start to, put our feet in shoes that don't allow our foot to do what it's supposed to do, we just start decreasing all of that sensory input. So I think from a rehabilitation perspective, one of the easiest things we can get our patients to do is, just have them feel the ground a little bit. And some of them will be like, you want me to walk around barefoot, like even in my house? I'm like, yeah, try it. I mean, it's a transition. Like, you can't just, especially, with some patients, obviously, that have diagnoses with, that don't like shock. You have to transition, but eventually those changes happen, and I think it's mandatory and it needs to.
Yeah, it needs to happen. I like it.
What's kind of your checklist that you go through on a gait eval? So like what's those of us who heard you talk today, we know, but like for the listeners who weren't here today, like what is sounds like you like an overall picture to start with, and then you start kind of going like a joint by joint approach in your evaluation?
Yeah, I like to look kind of globally first. So to kind of take a step back and just watch the person and how they interact with their environment. And I think that's even more so than, when I'm like, okay, now you're going to get on my treadmill. It's more of like how they're walking back to my office, things like that, where you can start to pick out kind of key things that they're doing. But taking a global perspective first, like I mentioned this morning, looking at their person. How do they look comfortable? Are they, wincing? I mean, that's aggressive, but you'll be able to pick up on some of those little nuances. I'm a big listener. I like to listen to how they're walking. You can hear a lot. You can hear foot drag that would indicate, the inability to dorsiflex the foot, for example, on swing phase. You can hear foot slap. You can hear, pelvic shifting because one side will be heavier than the other. It's interesting because once you point out those things to the patient, then they start to hear it. And then you're bringing them into a world of them starting to understand what's happening. And I think that's key, is education, especially with this stuff. Because you don't know.
No.
So this is naturally kind of, I'm assuming, giving you a niche for runners, or do you see a lot of runners, or are you like, because when you hear gait, you think more of like walking locomotion, but are you, do you look at runners? Is that like also something you do, or is basically walking kind of the thing that you're known for?
In Colorado, it's, I always say, just when you think you're in good shape in Colorado, you look to your right and somebody's there just gonna crush you. It's like there's no 5Ks in Colorado. People want to
they run the half.
Yeah, they're doing an ultra race, which poses its whole other set of issues. But I like all of it. I like watching just someone who wants to walk around the block, right? How do they improve their efficiency? And then from the running world, that's a whole breed, right? Because they're going to run no matter what.
Yeah.
And I think it's fun. It's being able to dial into their mechanics and be like, okay, how can we make you a more efficient runner, right? And it's fun once you start to see that, because when you see a really good runner in their gait, it's a beautiful thing to watch because it just looks pretty. It's soft, it's quiet. And you can pick out a lot and trying to improve that. And at the same time, I think on the other side of that, some runners don't look pretty and they still can run really well. And you're like, do I touch that? Like we were just looking at a patient on our break, and you see his foot like severely pronating in mid stance. He's running a 2:20 marathon. It's like, he has a difficult time propelling forward. Do you go down that rabbit hole of addressing that? I mean, I think that's a clinical decision.
Yeah.
but you do like sufficiency tests maybe, right? To see if eventually is that tissue going to break down.
This morning we kind of talked about your first half hour is basically about the different evolution of different hominoids and like how we've kind of evolved. So as we learn more and more about that, how important do you think that is? I know Thomas Schaud's also big on that. Do you think that is like important for really understanding gait, to kind of know like how this has all evolved?
I think it's so interesting, right? Because all those key evolutionary, like if you look at the different species and what really triggered those key adaptations, they're all things that we're still treating today, right? So lumbar instability, and the first thing of becoming bipedal, the ability to control frontal plane when the pelvis started to change and we started to have hip abductors, especially down at the foot. It's cool, right? Like once the groove of where the tibialis anterior sits, it changed where it was on the foot, and so we started to have midfoot stability and the variations of all of that, right? So that's why like you see so many variations in the foot, and you just can't say, well, every foot has to look like this, because it's just not the case. And I think it's because we're still adapting. It's still an evolutionary change. And I think we're kind of screwing it up, though, because of footwear, for example, and the fact that we ignore rehabilitation at the foot with a lot of our patients.
Right. Or we do a lot of passive treatment to the feet. Like we do a lot of manipulation, soft tissue work, and it's kind of, I don't know why it is, but it's, because I feel like everybody knows to stabilize the low back. I mean, that's a given fact. But then like when we talk about the foot, for some reason, people struggle with like, good rehab approaches for, turning muscles on in the feet. And I don't know why that is, but that's definitely, for some reason, it's a problem.
It's like, even when I'm watching a patient, I'll just ask them like, where do you feel tension on your feet when you're standing? And it's always such a window, because they'll be like, well, I feel it on the outside of my right foot and the inside of my left heel, right? And it's just a static position, right? So I mean, you have to realize that is, we don't move statically, right? So we have to assess dynamically, but it's always so consistent with things that you'll see. That they're starting to load certain structures in their stance mechanics, and then you can see that when they walk, and it's just it's a precipitation for what you're going to see down the road.
Why is this so neglected, do you think? Why is gait evaluation not taught well in school, whether it's PT, chiro? What is the actual reason on why?
That's a great question, and I think it's difficult. Like we had a half a semester in chiro school on foot and gait. And the solution when we were in school was, you'd go into chiro school and they'd be like, everybody's going to get 2 free pairs of orthotics, and
from a certain company, and
that's what you do, right? And it's crazy to me, because it's like, wait, what are we doing? We would never do that anywhere else in the body.
Right.
You would never be like, hey, there's this back brace company, and everybody gets 2 back braces, and you can just wear those the whole time you're in school.
Right.
But you get 2 semesters of microbiology or something. And this is something that you'd be doing all day long. How much are you giving advice on footwear to your patients? Sounds like from this morning quite a bit. So
every day, every single patient, and knowing like where they fit on the, like I'm on a pretty big mission to really educate on that, because I've seen so many incredible results with changing that, and some people aren't quite ready to hear that. They don't want to go down that road of, I can't wear this shoe anymore. So you have to really watch how you have to be able to assess and read the patient and meet them where they are. We want to be inclusive with all of this, footwear stuff, not exclusive, and be like, you need to be in a barefoot shoe but I do think that there's certain criteria in footwear that are necessary, and one being a wide toe box. And that shouldn't be that difficult of a concept for people to really be sold on. So
let's just take women's dress shoes, for example. So what are some wide toe box shoes that you may recommend for that? I know you have a website where you talk about a lot of this, but just to kind of tease it a little bit.
In the U.S., there's less companies, but Lems and Xero, XERO are both shoe companies that have wide toe box shoes. And there's a difference between a wide toe box and a wide shoe. So that's a big factor there. I've actually called companies and I've been like, this is BS. Like, this is not a wide toe box shoe. Because the last of the shoe, or the sole of the shoe, is very expensive to change. So what they'll do is they'll change the depth of the shoe, like the volume. So when people go to put the shoe on, it's like, oh, I have all this room, and it's like, well, you didn't really do anything. All you did was change the volume in it, and that still can, it's going to compromise the function of the foot. So Lems is a good one, Xero is a good one in the U.S., and then over in Europe, I mean, Ahinza, Balenka, Wildling. There's just a bunch of them out there now.
And where you have this shoe guide on your website, correct? What's the website?
GaitHappens.com. But then under favorite products, there's probably 20 companies there now, and they're coming out more. Soft Star is another one out in Oregon. Really wide toe box on those guys. But Ultra and Topo Athletic are the only running shoes that have that wide toe box. And it was really interesting. So we interviewed Golden Harper, who was the founder of Ultra. And he actually lives in Golden, Colorado now. So I see him quite a bit. Right? But his parents own a running shoe store in Utah. And when he started messing around with this, he would take the shoes in that shoe store, take them to a cobbler, cut down the heel, and put them at a Xero drop. And they started seeing changes in, diagnoses, plantar fasciitis, which you would think, well, if I drop the heel down, wouldn't that put more tension along the calf and along the foot? So that's kind of how they all got started, and I do love that running shoe. And what I am finding, I think that's very interesting also, is I used to transition people down. So if they were in like a 10 millimeter heel to toe drop, you would be like, wow, you can't go from 10 to 0. But if you match the stack height, right? So if I have a shoe with a stack height of 28 millimeters, all right, with the heel to toe drop, Ultra has a stack height with 28 millimeters. So you match the cushion, but you still allow the foot to be in that functional position. So you still get the benefits of the foot being allowed to do what it's designed to do, and the cushion helps with the transition. And then you can start to cut the cush once the foot gets stronger and the mechanics get a little more efficient.
That's amazing.
Yeah, it's been pretty, and patients love the shoe. Benno Nigg has done a ton of research with all this foot. I mean, he's probably had published over 100 articles, and he's done a lot on this. And he was quoted saying, when it comes to footwear, to prevent injury, the research will show you it's just being comfortable in the shoe. Comfort trumps everything else. And you put someone in a shoe that has a wide toe box versus one that doesn't, it's a no-brainer. It's like, of course this shoe feels better and more comfortable. It's pretty cool stuff.
Let's bring up Pandora's box, orthotics. So when, I don't know, let's keep it real general. If you had 100 people with foot pain, what percent of those 100 do you think need to be an orthotic? That's kind of an easy way for people to start thinking about it. Are you doing less orthotics now than you did 20 years ago or 15 years ago? What's your current thought on orthotic therapy?
Yeah, it's changed so much. I mean, when I had my practice in Chicago, which was 10, 12 years ago, I probably casted 50%, 60% of my patients. Because it was like, when we were in school, it was like, oh, you have foot pain? You need an orthotic. I think now maybe I'll cast 3 to 5 a year.
I'm kind of there.
Yeah.
Maybe a little bit more, but not, I mean, that's probably where it's at. That's probably the right number.
It's orthotic. I think it needs to be viewed as orthotic therapy. Like, there is a time and a place for that, right? If you look at the research on treating plantar fasciitis, for example, 2 weeks up to a year, orthotics can help. But the problem is our patients go in, they get an orthotic, it helps them with their plantar fasciitis for a short period of time, but then nobody ever tells them, hey, you need to get out of this thing. Or you need to strengthen your foot, or this should be, what is your exit strategy to get out of the orthotic?
It's a forever thing. Yeah.
It's a forever thing. And then they're like, well, I've been wearing these orthotics for 10 years and now, I can't lift my big toe by itself. I can't, propel off my foot. And you're like, well, yeah, you've been bracing your foot for 15 years.
Yeah. So you would maybe agree with the goal of orthotics is to rehab out of orthotics?
Unless there is a structural variant that you can't overcome with function.
Do you have any examples of like some of the big hitters that you are seeing that orthotics are the only option that you...
Severe torsions, like severe tibial torsions, like internal tibial torsions, sometimes those cases, tibial varus, forefoot varus. Now those are only going to be about, a true forefoot varus is going to be maybe 1% of the population, but when you start treating foot and gait, you're going to see them.
Yeah, you're going to run into them.
But
it was interesting talking to Tom. We talked about forefoot varus for a while, Michaud, and he originally had our opinion of this, and then he's like, anymore, I'm not convinced I need to do anything from an orthotic. And that was always one of my steadfast criteria for an orthotic was that. That's really, really interesting.
I mean, I think other than that, I really think that you can rehab the foot to better, build a stronger foundation from the ground up, and then the whole body just starts to work better. It just starts to be more efficient.
Tom also says, he says, I always ask myself a question of, do I need to redistribute pressure here? Yeah. And if I do need to do that, then an orthotic can make sense. Because you can also redistribute pressure with treatment also. Yeah. So the question is, if I've not done that with my treatment, then, will an orthotic aid in that process, So, and then now all the, the rage and the debate of do we really need to cast people? You said, and Tom got me thinking about with the postings with you may see the whole casting literally just go away. Yeah. And I think, you could do a trial of care with these postings and then eventually do something more permanent off that.
Yeah, he's done, so he has those varus posts now. So there's one in the forefoot and then one at the rear foot. And he actually mentions a couple studies on his site that he was looking at. But obviously it's, helping to control some of the internal rotation, so the knee valgus, things like that. But with the posts, you can still actually improve strength. All right, which was really interesting. And it's less stuff. It's so easy. It's like a self-adhesive that he's designed that you put on the factory insert. And we had this conversation the other day because he was originally stating we needed both the forefoot and the rear foot, but now it's you can even dial that down even less.
Not one or the other. That's
and
awesome.
Just do and then especially if it starts to help patients, right? And then you're like, okay, now I know what I need to do to help to restore function at the foot. And it's fun to watch. It's fun to see.
It's amazing. Yeah, I love it. Well, what a cool little insight. We tried really hard this time to keep it around 20 minutes, and so we're doing really good. So we could probably talk for days about orthotics and foot rehab and different changes and stuff like that, but we're going to cut it now because we got to go in and keep watching. We're at the R2P Symposium this weekend, and Courtney, thank you so much for sitting down with us. We learned a ton from you this morning, and we can't wait to keep learning from you, and I'm sure we'll have another conversation at some point. So that'd be awesome. So any closing thoughts, Brett?
No, I'm just, like you said, we've learned a lot already from her lecture today, and then we're looking forward to seeing some patients later, and we can all kind of come together on some ideas for treatment.
I love it. Well, is the best place to get a hold of you and figure out where you're at and stuff Gait Happens?
Yeah.
Instagram, Facebook, online, all that good stuff.
All that good stuff.
I love it. She does amazing stuff on Instagram, so if you're not following them, Gait Happens, then definitely do. So I love it. All right. Thank you so much, Courtney.
Thanks.
See you guys.